Today's topic is orbital cellulitis. So I want to make your concepts a bit better. It's a very important topic. As you know, any cellulitis means inflammation. Means inflammation. Means inflammation. Means inflammation. So orbital cellulitis means inflammation of the soft tissues of the orbit. Means inflammation of the soft tissues of the orbit. What are the soft tissues in the orbit? First, if we see the lid, there are muscles in the lid, like orbicularis, like levator palpebral superiorus. Then we have the orbital septum. Then behind the orbital septum we have periorbital fat. We have the muscles. We have the retrobulbar fat. So these are the soft tissues in the eye. They are the soft tissues in the eye. First of all, next.
Huh? So we're spinning your head. तो she next वाली पुरानी वाली में आफ्नो छन्
So first thing, I will talk about the orbital cellulitis. Silence please. So orbital cellulitis is inflammation of the soft tissues of the orbit. Generally we classify orbital cellulitis into preceptor cellulitis and orbital cellulitis. Preceptor cellulitis and orbital cellulitis. Classify it as preceptor cellulitis or orbital cellulitis. Orbital cellulitis is also called postceptor cellulitis. It's called postceptor cellulitis. What is the septum? What is the septum? What is the septum? Septum is the fibrous tissue. It's a fibrous tissue which is from the superior orbital ring. Which is from the superior orbital ring. And which gets attached to the tendon of levator palpebral superiorus, LPS. So once we have orbital septum, we have the orbital septum. So any inflammation in front of that is called preceptor cellulitis. Is called, and any inflammation behind that is called postceptor cellulitis, or other name is called orbital cellulitis. So we have classification. Preceptor cellulitis and postceptor cellulitis. So if we go now, you are not allowed. Why you are coming late? Why you are coming late? What come to the come up. So we have the receptor cell lines and the photoreceptor cell lines. So if we classify them, there's receptor cell lines, post-receptor cell lines, then we have the complications of the cell lines. What are the complications of the cell lines? Cell lines can cause abscess. It can cause abscesses. It can cause periosteal abscess. It can cause periosteal abscess. It can cause orbital abscess. It can cause orbital abscess. And then the third is it can cause cavernous sinus thrombosis. Cavernous sinus thrombosis. And number 4 important, it can cause perforating abscess.
मर गया इसमें
So this is the classification. So if we go by the symptoms, before we go to the symptoms, we will see why it is caused. There are different mechanisms, causes. What is the cause of cellulitis? Cellulitis is an infection. It's an infection. So where from the infection come? Normally it comes from paranasal sinuses. It comes from the paranasal sinuses, especially in children. Then once it comes from paranasal sinuses, then other possibility is what? It can come from the lacrimal sac. Number 3rd possibility is it can come from lacrimal sinus. Number 4th possibility is it can come from the dental root. Okay, dental infection. Number 5th is it can come from where? Septicemia. If somebody has septicemia, it can lodge in the orbit. It can cause orbital cellulitis. Number 4th is important, trauma. Suppose somebody is hit by wood or something, and if the foreign body gets lodged within the orbit, it can cause orbital cellulitis. Other trauma is surgical trauma, like injections in the periorbital space, like intraocular surgeries. That they can also lead to orbital cellulitis. One more important thing is what can cause orbital cellulitis is the endocarditis. What type of endocarditis? Infective endocarditis. What is that called? Septic endocarditis. Because there are septic emboli coming from the valves of the heart, which can lodge anywhere in the body. That's called embolic orbital cellulitis. So these are the causes of the orbital cellulitis. If we then see the organisms, what are the organisms which cause it? Normally, which organisms cause it? Normally, caused by streptococcus. It's called by streptococcus. Then it is caused by staphylococcus. Then it can cause by pneumococcus. So these are the common organisms. So streptococcus, staphylococcus, pneumococcus. Then we have the Haemophilus influenzae. Then we have the Pseudomonas aeruginosa.
खोलूं
are the bacterial organisms. These are the bacterial organisms. Why you are going to say? Next time I will not allow you to work. This is the first and the last problem.
सर आप फिर से कोई
The problem with me is I have to say everything again, repeat. Because you people will not understand what I have told. Now onwards. So I request you everyone to come on time. Next time I will not have. This is the first and last time I am learning. And if anybody talks here, I will fashion you. So again I will repeat, orbital cellulitis is the information of the soft tissues of the organ. We have the orbital septum, which is from the upper bony margin, which gets attached to the tendon of LPS. Anything in front of that is called preceptor cellulitis. Anything behind that is called post-septal orbital cellulitis, or other name is orbital cellulitis. Then we have the third thing, that is the complications of the orbital cellulitis. That is the periosteal abscess, that is the orbital abscess, that is the intracranial abscess, that is the cavernous sinus thrombosis. So these are the four complications of the orbital cellulitis. Then we have the organisms. Organisms are gram-positive, streptococcus, staphylococcus, then pneumococcus, then gram-negative, we have Haemophilus influenzae and Pseudomonas aeruginosa. Then we have some fungus. We have some fungal organisms. What are those fungal organisms? Mucormycosis, which got very rampant during the COVID. You understand? That's called that's called mucormycosis. Other fungus which can cause is aspergillus. Is this aspergillus? So these are the two fungi which can cause orbital cellulitis, aspergillosis and mucormycosis. As you know, that the fungus cellulitis is more common in those people who are immunocompromised. So diabetes, like COVID, or somebody on immunosuppressants, they are the person who are more prone to the fungal orbital cellulitis. Then we have the some parasites we can cause also. This, like echinococcus, like Toxoplasma gondii, like Taenia solium, they can also cause orbital cellulitis. These are the organisms. These are the organisms. So I told you three things. First, what's orbital cellulitis? Why from it does come? Then what are the causative organisms? So where from does it come? I will again repeat. It comes from the paranasal sinus usually, especially in the children, like ethmoidal sinus, like the bacterial sinus, from the dental infections. Okay, then it can come from the trauma, which is the lip trauma, or it can come from the surgical trauma, or any foreign body which goes into orbit. It can act as a knife of cellulitis. Then we have the heart, which can cause subacute endocarditis, which can lead to septic embolus, which can lodge anywhere in the body, and orbit is one of the sites. Then we have one more, lateral sac. If there is somebody has a chronic necrocystitis, that can also lead to orbital cellulitis. Then we have one more, surgical trauma, eye surgery, like endophthalmitis, or any eye surgery can lead to infection, intraocular infection, what is called endophthalmitis. And that endophthalmitis can lead to orbital cellulitis. And we have one more classification, what's called exogenous and what is called endogenous. Exogenous and endogenous. Exogenous means from outside what can come. Endogenous is from the inside what can come. So Organisms can come from outside also, distant side, or they can come from within also. Then this is the classification what I have taught. Then one thing I want to just put it in your brain. There is one science which is more common, which leads to endocrinite, and sorry, orbital life in children especially. That is the that's what ethmoidal science. That is ethmoidal science. Why it leads to orbital life? Because it has three reasons. Medial wall of the orbit is thin. It is thin and it's very close to the orbit. And number second, there are some emissary veins which are going from sides to the disc. And there are some holes through which some structures are passing. So they act as anatomical anatomical weaknesses, which can lead to separate the cellulitis from the ethmoidal sinus to the orbit. So again, I will repeat three things. The bone in the middle orbit is thin. Number one. Number two, the emissary veins are connected from the ethmoidal sinus to the orbit. Number three, that there are some anatomical holes or through which the arteries or nerves or whatever are passing, and they act as a source of transmission of the infection. So these are the three causes why orbital cellulitis occurs more commonly in ethmoidal sinus. Ethmoidal sinusitis. Then we want to know again why orbit there occurs more infection. Why there is more infection in the orbital cellulitis? Why? Because orbit is a compact structure. It's a compact structure. Remember these three things. It's a compact structure. Number second is that the infection leads to thrombophlebitis. Infection leads to thrombophlebitis. Once there is thrombophlebitis, what can happen? What can happen? What can happen? It can lead to edema. Exactly. So once there is edema, it gets trapped in a closed space. It gets trapped in so orbit is a tight space. It's a tight space, and edema or this cellulitis infection, inflammation leads to thrombophlebitis, and thrombophlebitis causes more fluid accumulation within the organ. Then we go now directly into the suppose the pathogenesis you can read yourself. Once there is some infection somewhere, the leukocytes will go there. Okay, that you know, polymorphs and this. Once there is infiltration in some area, while there is infiltration in some area, it leads to the necrosis of the tissue. Once it leads to the necrosis of the tissue, it will lead to the pus formation. Okay, so there is an abscess formation there. So now we have reached to that stage where we can discuss now clinical aspects of the orbital cellulitis. So a patient enters into my OPD and he enters into my OPD and I have to now decide whether this is preceptor cellulitis, it is post-septal cellulitis. Why is it important? Because it's important because preceptor cellulitis is not that dangerous. It's a benign condition. It can be treated easily. While orbital cellulitis is an emergency. It's an emergency. What first thing you have to do if you diagnose orbital cellulitis? You have to admit the patient. You have to admit the patient. You cannot send him back. So suppose patient is in my OPD and I look at the patient, I see some lid edema. I see a lid edema. That's all he has. There's some lid edema, the rest of the things are, I send him for the vision, it's normal. I check his pupillary reflexes, they are normal. I check his point, it's normal. So what I will label it as? Preceptor cellulitis. One more thing, the extraocular movements. They are normal. So that is what differentiates preceptor from the post-septal. So preceptor cellulitis, there will be some lid edema, There will be some lip edema. It will not be that gross, but there will be some lip edema, and vision will be normal. Pupillary reactions will be normal. See, there can be some conjunctival chemosis. The fundus will be normal. Okay? So we label as preceptor cellulitis. And what treatment I will give? I will just give an amoxicillin, like 625, 8 hours in adults. In children, we will lesser dose. Then I can give any analgesic or anti-inflammatory, like brufen, diclofenac, like that. Then I will give some topical antibiotic drops. Okay. Then I will give some antibiotic ointment at the bedtime. That's all. Now, if the patient is coming to me and he is having a very gross edema, very gross lip edema, that much of lip edema as if the eye is totally closed. Okay, so somehow I managed to open the lip. What I see here is a gross conjunctival chemosis. There is a gross conjunctival chemosis. Then, once there is a gross conjunctival chemosis, I check his pupillary reactions. It's not right. There is a relative afferent pupillary defect. There is a relative afferent pupillary defect. Then, if I check the eye movements, they are restricted. They are restricted. And if I check the relative position of the eyeballs, right and left, there is a proptosis. The eye has come forward. Eye has come forward. And if I check his fever and other things, fever, there is a fever, pyrexia. So these are the things which differentiate orbital cellulitis or post-septal cellulitis from the preceptal cellulitis. So if the patient has fever, he has lamps, he has headache, then he has a decreased first gross lip edema, which is almost painful, or that can be sometimes, if that's due to edema, that can be non-tender also. But there's a gross lip edema, there is proptosis, there is a decrease in the vision, then you have the restricted eye movements, then you have the relative afferent pupillary defect, the pupil is not reacting. So these all point to the orbital cellulitis. That's how we clinically differentiate. Then what I will do with that patient? What I will do is that I will admit that patient. I will admit that. Number second, what I will do? I will start with an empirical antibiotic therapy. But the antibiotic therapy should be IV. It should be, don't give oral. Don't give oral. So IV antibiotic therapy. Before giving antibiotic therapy, what I will do? I will take samples. Now while I will take samples, I will send a blood sample. For what? I will send for CBC. I will send for hemogram. Okay. I will send for ESR. Then what else I will do? I will tell the patient if there is some pus here or something, I may take a culture of it. I may take it. What for I will send it? I will send it for the culture sensitivity. Then what else I will do? I will then start the antibiotic therapy. I will give an IV dose. And meanwhile, I will send the patient for the CT or MRI or ultrasound, B-scan ultrasound. What I want to look in the CT or what I want to look in the ultrasound or what I want to look in the MRI. I want to see how much is the abscess, where there is periosteal abscess, where there is cavernous sinus thrombosis, or where there is intracranial abscess. So CT MRI will tell me everything. And if now I have started the IV therapy, if I say what drugs we can give? What drugs we can give? We can give vancomycin, we can give vancomycin, we can give third generation cephalosporin, cefotaxime. Okay, then we can give piperacillin, tazobactam combination. Okay, but in high dose. like 5% calcium is given around 4-5 grams TID, like that. Even the vancomycin is given 3-4 grams a day. So I start a empirical antibiotic therapy. Then I will start an anti-inflammatory therapy. I told you, like Grofin, diclofenac, what else. Then after 24 or 47 hours or 48 hours, I will reassess the patient, whether the patient is improving or not, or whether there is a surgical indication of drainage of the abscess. And in the meantime, I will assess the CT and the MRI, whether the inflammation is resolving or it is increasing. Okay. So if there is suppose a subperiosteal abscess somewhere, what you will do? Abscess is golden rule. Abscess is a golden rule. Drain. Okay. Whether it is a subperiosteal, whether it is intracranial abscess, or it is in the orbit. So wherever there is abscess, it needs to be drained. Suppose patient is landed into non-cavernous sinus thrombosis. How you will come to know? Patient is developed orbital cellulitis, and now there is cavernous sinus thrombosis. Yes. So there will be cranial nerve involvement. So which are the cranial nerves which pass through the cavernous sinus? Like 3, 6 or 4, whatever, or even trigeminal first segment, like that. So these are the nerves which will get affected. But before that, what will happen? Patient will have altered sensorium. Patient will have altered sensorium. He will not respond the way he was responding before. So altered sensorium with these paralysis of these cranial nerves. Superadded, there will be proptosis on bilateral. Bilateral proptosis, one of the differential diagnoses is cavernous sinus. So you have to keep that in mind. So I have told you investigation, I have told you the treatment, you understand, and I have told you how you can change the progress of antibiotic. If the vision is improving, that means patient is responding. If vision is deteriorating, lid edema is increasing, that means patient is not responding. Okay, so these are the principles. एक मिनट आप इस स्लाइड फिट कर दो एक मिनट. ठीक है. Just I want to show you something. Almost I taught you everything. Just I will revise it. If I have missed this one classification, just I told you that preceptor cellulitis, orbital cellulitis, subperiosteal abscess, orbital abscess, and cavernous sinus thrombosis. This is not a classification in the strict sense. Classification generally happens. This can lead to this, this can lead to this, this can lead to this, this can lead to this. But it is not necessary. If we control it here, it is gone. Okay. So if we control it here, it is gone. Okay. If we control it here, it is gone. So if we are not treating it properly, then it can go to this. Okay. So first important thing is that once you see a preceptor cellulitis, treat it properly. Otherwise, patient can lose the eye and he can lose the life. Because orbital cellulitis can ultimately lead to septicemia. You understand? Next. That I go next. So suppose this is a gross lid edema. This is a gross lid edema. So we will label it as, most likely, if we do an examination, this will fit into orbital cellulitis. This is orbital cellulitis. Next. Again, this is some trauma here on the lids which has led to orbital cellulitis. Next. So these things I have told you. Next. So I have told you that there can be extension from lacrimal sinuses or this direct extension, or they can be embolic from the heart. Then the paranasal sites are very important. These are the majority. Orbital cellulitis number one causes paranasal sinuses. And among the paranasal sinuses, there is orbital sinus. Okay. Then these are the next. Okay, next. Exogenous, endogenous, I have told you. Surgery also I have told you. Foreign bodies also I have told you. Next. So, that is exactly. So, from this you know that occurs with edema once there is occurs infection, then it can lead to proliferation of the organism, then it can lead to abscess formation. Next. From pathology you know. This is very important. Two things I told you already. Orbit is tight compartment and there is a thrombopilvitis. But third thing is it is absent lymphatics. It has. So it does not have a defense mechanism in the body. This is very important. Generally people say eye does not have lymphatics. But there is a controversy, maybe conjunctiva has some lymphatics. But within the orbit there are no lymphatics. So a tight orbit, no lymphatics, and number third is a thrombophlebitis, which leads to a severe orbital cellulitis. Next, these bacteria, parasites, fungi, I have told you the names of the organism. Next, cultures I have told you, children I have told you. Children, the most important is the step bodies. Even in adults, step bodies are equal. Next. Suppose you have diabetes, suppose you have immunocompromised, you have always, the infection will be more severe. So you have to treat it more aggressively. And number second is you have to always keep in mind, maybe this is a fungal infection. Suppose this is a fungal infection, what you will do? So you will not use antibiotics. What you will do? Antifungals. Which antifungal? Amphotericin B. Amphotericin B. So you have to use in that case amphotericin B. These are the organisms, parasites. Next I have told you about this. This is following a eye surgery. It has happened in orbital cellulitis. Next, these things I remember this. In fact, you take a pic of this. Everyone take a pic of it. So these are the features of orbital cellulitis. And edema and visual impairment, raised IOP, restriction of the ocular movements, proptosis and the chemosis. So remember these five. Remember these five. So if there is proptosis present, these three are important. Proptosis, visual impairment and restriction of ocular movements. If these three are present, it's orbital cellulitis. Don't confuse yourself with this cellulitis. Okay? Proptosis, restriction of ocular movements and the visual impairment. Next, please.
So next here.
That I told you that other complications. She has put one or two more complications more. Optic neuropathy. While there will be high pressure in the orbit, it can lead to high pressure, it can cause compress the optic nerve. It can cause optic neuropathy. CRVO, central rectal vein occlusion, it can cause because there is a raised IOP in the eye, so that can cause. Cavernous sinus thrombosis, that you know. Orbital abscess, you know. Intraocular secret of infection, it can go from outside to in. The way infection go from inside of eye to the out. What is that called? Suppose there is a inside eye infection, that's called endophthalmitis. That's called. Now there is signal involvement. What do we call it? That's called panophthalmitis. That's called panophthalmitis. Now it goes beyond sclera into the orbit. It is called orbital cellulitis. So intraocular infection can lead to orbital cellulitis. Now if there is orbital cellulitis from outside, it can cause scleritis or panophthalmitis or endophthalmitis. So it can spread that way also. There is one thing I want to stress this point. The exposure keratitis. How it will happen? Because there will be proptosis, the cornea get infected. Once the cornea will get infected, it will become an exposure keratitis. Next. So this is some discharge of orbital abscess here, shown like this, in the lower leg. Huh? Next. These you know, these are the complete hemogram important, blood culture important, CSR important, then even I think C-reactive protein, CRP. You understand? Because that will tell us the weight of infection. Then the CT, MRI, and the ultrasound. Next. Next. There is a difference between CT and MRI. What is the difference? CT will tell you about the bony tissue, and MRI will tell you about soft tissue. So MRI will be more informative because it's soft tissue infection. It is not a bone infection. Next. So if you have access to MRI, one should go for MRI instead of CT. So antibiotics, anti-inflammatory. One more is because this is a science-related problem. Is it? Science-related problem. You can give nasal decongestants. You can give. That will drain the sinuses. That can help in the resolution of the infection. But once you are sure, it is due to sinusitis. Next. Previously. Surgical intervention, I told you, once 48 to 72 hours of antibiotic therapy, patient is not responding, you take a CT MRI, there is some evidence of abscess formation, you can go for surgical intervention. Or in, suppose MRI shows cavernocytis thrombosis. Or okay, in that you don't surgically intervene, but suppose it shows intracranial abscess within the brain. It needs to be drained. It needs to be drained. Next. So suppose there is a subperiosteal abscess. You will give a curved incision. You will go under the periosteum. You will drain. Okay. Then if there is an orbital abscess, it's an orbital. Again, you have to go into the orbit. You have to drain. You understand? Suppose there is brain abscess, you have to open the cranium, but it's called craniotomy, and you have to drain from the brain abscess. Next.